Welcome to the office. Welcome to the office, Ollie. What brings you here from Texas?
Well, I dislocated my shoulder.
Which shoulder?
My left shoulder.
Okay, it was a full dislocation?
Mm-hmm.
Okay, when did that happen?
February 10th.
So a few weeks ago, a couple weeks ago.
Mm-hmm.
What were you doing?
I had a soccer game.
Okay.
And I was going for the ball, and somebody on the other team kind of put their shoulder into the back of my shoulder, and then it came out.
Okay. Is that the first time this has happened?
No.
How many times has it popped out?
This is the 5th time.
When was the first time?
The first time was October 2019.
Okay. Playing soccer?
Playing football.
Playing football.
Mm-hmm.
What position?
I was playing safety, and I was going for a tackle.
Oh, so you're quick. All right.
And my arm kind of got caught over here.
You're talking about this
arm?
arm?
Yeah, this arm, but
Okay.
Can't really move it.
Sure.
So then it came out, and they put it back in like 2 minutes later.
Mm-hmm.
And then...
And you played?
No. I sat out the rest of the football season to get ready for the soccer season, while like PTing it.
Mm-hmm.
And then December...
PTing means what? Doing like ultrasound, E-stem, rehab, exercise?
And exercises.
Any therapies? Like ultrasound? No, just straight rehab.
Mm-hmm.
Okay. So that was the first one.
Mm-hmm.
And then did you do anything besides PT on the other ones?
Well, I got surgery after the second one.
What surgery did you get?
A labrum repair.
Labrum repair, the whole labrum? Front, back, top, bottom? Mom?
Just the front.
Just the front. Okay. So it popped anterior,
Yeah.
right?
Yeah.
And what is the labrum? What is a labrum? They
That's
tell
a
you what a
good
labrum
question.
is?
No.
Okay, it's very simple. Labrum is a disc. Now, unfortunately, I don't have a shoulder model, but I'll demonstrate with my hands. So let's say this is the glenoid fossa and the humerus sits in there, right?
Mm-hmm.
The humeral bone makes a shoulder complex. The labrum is fibrocartilage, and it's like a spacer, a disc, but it creates a vacuum that sucks it in. The humeral head sucks into the labrum.
Mm-hmm.
But how does that stay in anyway? It stays in, and we're going to get in more detail, because of the sits muscles and the power that comes from the lower cervical spine. And we'll get into that later. So they did an anterior labrum reconstruction, cleaned it up. Okay. Did they add anything to it at that point?
I know they put anchors, but I don't know what that was for.
They didn't add anything.
Okay.
They didn't add anything to the labrum.
No.
They had no jelly or anything, or
No.
any cartilage or ligament
No,
or tendon
nothing.
from something. Okay. 5 dislocations.
Uh-huh.
First one was relocated.
Mm-hmm.
Second one was relocated.
Mm-hmm.
Third one was labral reconstruction.
After the third one, I didn't get anything. I kind of just rehabbed it. I got my surgery after the second time it popped out,
Okay.
and then
Third and fourth, we had no surgeries.
no.
You just dealt with it and went back to playing.
Well, the third one was about 7 months after surgery, and then I took a break from all my sports,
Okay.
and then rehabbed it again.
Okay.
And then it held up for about like a year and a half until last June,
Okay.
June 6th. It came out when I was swimming. It hit the water like this, and then it came out also anterior.
Just front stroke,
Mm-hmm.
and then the fifth one was just now.
Yeah.
And now we're here.
Mm-hmm.
Okay. Before we get into that, what else is going on with you? You were talking to me about your shins.
So I've also had stress fractures in both of my shins and bad shin splints.
When did that happen?
It started
We're talking shins here, shin splints, anterior here, tibia.
January 2021.
Okay, so it's a couple of years back.
Mm-hmm.
They tell you why? You're just playing too hard? You got weak bones? What's up?
No, they didn't really tell me anything.
Okay, just deal with it, let it
Yeah.
heal up by itself, right?
Mhm.
You've obviously had inversion sprained ankles at some point,
Yeah.
right? I'm sure. You gave it as much as you got it?
Mm-hmm.
All right, it's okay, good. Okay, let's go back now and let's rewind. This is good for people to understand what's going on here. First is having this information, and I know your parents didn't have this information back then. They have it now, right? You didn't have this information. And most parents don't have this information. So let's talk about the shoulder and the shoulder complex.
Mm-hmm.
The way I was trained with the shoulder, okay, and I was trained by the top chiro, one of the top chiro extremity guys in the world. When we look at any shoulder condition, right, the shoulder is the only joint under 100% neurological control. Follow my process, my thought process. They did these studies decades ago. They did animal studies. And what they did is they severed nerves going to all the different joints in the body, to the shoulder, to the elbow, the wrist, the knee, the ankle, the TMJ, all this stuff. When they severed nerves to those joints, the joints stayed intact.
Mm-hmm.
But when they severed nerves to the shoulder popped out. We know the sits muscles control, right? The rotator cuff muscles. But they are under constant neurological control and power, proprioception, from the cervical spine nerves. And it can go as far down as like T3, T4. And the reason I mention that is every shoulder case I've seen in 20 years always starts with spine. And hence why I asked your parents to come out and bring you out here, and let's evaluate the spine first. If a surgery is necessary, okay, you do what you got to do. That's not where I'm not saying 100% there's no surgery. I'm not saying 100% there is surgery.
Mm-hmm.
What I'm saying is I heard in the consult we have recurring dislocations of the shoulder or recurring dislocation of anything. First thing I'm thinking is there's a power supply issue. Something is off.
Mm-hmm.
Okay? And that's what we're going to check today, and that's what we're going to figure out.
Mm-hmm.
Now, when we're talking about shin splint, so this is the foot. We've all had the inversion sprains, as you have. Now, when we're looking at anterior compartment, we're looking at tibialis anterior, which attaches to the front of the ankle, right? When we have an inversion sprain, the first misalignment that occurs is at talus AS, anterior superior, and it can tilt one way or the other. When it's stuck, so it's going like this and then tilt, it's pulling, right? If you just bring your ankle up, we're exaggerating it, but let's exaggerate it. Let's say it's stuck like that. How are you going to walk? We're not going to have proper toe off. We have fixation in the hind foot. We have hypermobility then in the forefoot and the midfoot, right? So we start to develop these compensations. So the muscle starts to work different. That's where we get those from. Now, if you're telling me stress fractures if both talus are out, then it makes a little sense to me. Why? Check it out. If I'm walking and I'm exaggerating, right? So we're stuck in anterior superior medial tilt. How am I walking? Right? Choppy.
Mm-hmm.
So you're sprinting, you're walking, you're putting a lot of weight, but we're in this stuck position. Does that make sense?
Mm-hmm.
So we'll check that out. And all of this secondary to foundation. So we have shoulder, we have ankles, or anterior compartment syndrome. Anything else?
Oh yeah, my nose.
Tell me about the septum.
I got hit by a soccer ball once in 6th grade, and then ever since then I have had trouble breathing out of my right nostril.
Right side. And that was the only time you got hit in the nose?
One more time.
After?
Uh-huh.
Okay.
This was during it was snowing in Dallas, which isn't, doesn't happen too much, so we're all going sledding and all that.
Okay.
And then I fell off the thing and I hit my nose on the ground, and then it got a little bad after that.
Okay.
Probably a little bit worse, but it wasn't it was already kind of bad to begin with.
In terms of the breathing.
Mm-hmm.
So let's do this, Ali. Let's go over your x-rays. Let me explain what I see.
Mm-hmm.
We'll do our exam, figure out where we're going to start. We'll go over the x-rays of your spine. I specifically did not take shoulder x-rays today. I have your old shoulder x-rays that I looked at from the injury. We're going to take them in a couple of days once we get the power on and get some of that inflammation down.
Mm-hmm.
Fair enough?
Yep.
Okay, let's do it. This is the side profile. And the first thing I'm looking at in the side profile is the posture. Does the shoulder line up with the base? And it's not so bad. It's a little bit behind, but it's not so bad. I'm okay with that. In terms of, this is the base L5, lowest lumbar. It should be bisecting through here. Okay, so what it shows, we're slightly behind the foundation, the upper part of the body. And then what's the body doing in terms of compensation? It's starting to develop the opposite curve. Okay. And let's look at the foundation before we do anything. When we look at the foundation, what do we see? We have a short leg on the right. And when we look at the widths of the ilia here and here, they look different sizes. And those are x-ray projections. It doesn't mean that they're different sizes, right? Let's look at the numbers and see what's going on here. So mom and dad, I'm glad we came out, and this is why. When we look at his foundation, we have a current 11 millimeter measured short leg on the right compared to the left. We have a rotated sacrum on the left on this side. Sorry, the short leg is on the right. We have a rotated pelvis. I'm going to put this together and explain what this means. Now, in the work we do here, for any of these adjustments to hold, we need to be under 7 millimeters. Anything under 7 millimeters, adjustments will hold. We're at 11 right now. And this was the major thing that, look, we're down on the right side. We're compensating the upper body. We're probably going to have pressure here. How is this shoulder supposed to hold and stay in place? Right? PIEX, ASIN. We've listed both sides, but we'll find it on you in terms of which one we're going to deal with. We're not adjusting both pelvis. It's not common in this work that I do in the Gonstead method. Let's look at the left side since we have the rotated sacrum on that side. Your left side, left pelvis goes up 2 and it turns in 7. So it's favoring to the left side. The sacrum on that left side goes back with it. So the overall effect is what? Your body or your foundation wants to go left. However, the short leg is on the right. So I'm pretty sure when you walk, you got the Dallas wiggle, I'm pretty sure when you walk, okay? So the foundation goes this way, the short leg brings them back this way. We should be moving through our SI joints or our dimples this way. They should be going up and down, and we'll see it when we see you walk. Now, I talked about this side. If we find that this is the fixation, it's the exact opposite. If this is up, this is down. If this is in, this is out. So whichever one we decide is the issue that we're going to work on, the goal is to get that up. So you can see body is doing what? It's creating a slight curve to the right. Now the body is compensating to the left. And this is where the fun starts, dude. Now, the bones all kind of line up on top of each other. Even though the spine is tilting, that's fine. And some are rotating, that's fine too. But right when we get to this one, we have a side slip. T1, 2, 3, 4, 5. 5 is a side slip, 4 is a side slip, 3 is a side slip, 2. So it's like a stair-stepping effect of T5 up. If that's the case, we don't really have stability of the neck. You can see what is the neck doing. It's going with it and then it's compensating back. The nerves that come out of here are the nerves that control the shoulder. With the exception of there's the spinal accessory nerve that controls the traps, and that comes out of the upper cervical up top here. And when we look at the septum, you can see it right there. Overall, the discs are great. I'm happy with that. Let's look at his tailbone. You guys hear me talk a lot about tailbone injuries. That's really good. There's one right there. It's not so bad, but it's there. But in terms of everything else looks good there. We look at the discs. Starting at 5, you see a little bit of that tilting, and that's only because of slight curvature. The discs are fine there. There's more tilting on the A to P film, so it looks like it's just tilting. But right when we get here, you can see these discs are supposed to be level, parallel. It starts here. That's T5. Now let's talk about the neck and let's talk about the shoulder and how this relates. We know the neck is starting down low at T5, meaning it's not just let's adjust your neck and everything's going to be fine. It's let's stabilize foundation, but more importantly, what's going on here. This area also controls part of the digestion. So we'll talk about that stuff later as well. When we're looking at his curve here, this curve is going in the opposite direction. We want it to be going forward. So let's see which one is causing this. This is you in extension, this is you in flexion. In flexion, we have a disconnect here, a little bit here and here, but overall, this is good. But what this also tells me is we don't need to be touching this part of your neck. That's not the cause of anything. 7 didn't move. So if anything, we have something at 7. We should have a little more opening of this. We may have something going on in the upper cervical. I'm okay with that, but we don't need to touch 2 to 5. So the thing about the shoulder we talked about is what? Is when someone tells me I've had recurring dislocations, I've had knee dislocation cases, ankle dislocation cases, one here and there, okay, but someone with multiple, okay guys? When I'm seeing it, multiple dislocations that are not holding, there's something going on in the spine. It needs to be checked. Shall we get started? All right, let's do it. You're gonna walk to the corner of the room and back a couple of times, please. Go ahead and walk. Yeah, there's the Dallas wiggle. So when he walks, he shifts like this. He walks like this. His dimples go side to side. They don't go up and down. Turn around, please. Let me bring it down so your peeps back home can see this. Go ahead. You see that? It goes like this. It's got a tinkle. You got the Dallas tinkle. Walk on your toes, please. You're okay without the brace on your shoulder right now, yes?
Yeah.
All right, cool. You can see it more when he walks on his toes. Okay, turn around, walk on your heels, please. How is that for your anterior compartment?
I don't really feel anything.
Nothing right now, right? Okay. Turn around, keep walking on your heels, please, so we can see. You see the difference in his walk? So we want that to be smooth. All right, sit up straight, please, starting at the base of the neck. There it is. C7, left side, 5 points. 10 points, C1, left side. 10 points, T5, T6, left side. Oh, yeah. 17 points, S2, left side. All right, so we have down in the sacrum, T5, C7, C1. Next thing we want to do is check the pelvis and the foundation. Feet together, open and close the knees with your feet touching. Open and close. Open wide and close. Open, close. Good. Keep going, keep going. Butterfly. Mariposa. Right side only. Do the right side only. Keep going. So when he does the right, you can see the whole left shift. Do the left side only. So when he does the left, the right's pretty decent. So this is left SI joint. Okay. Come back slowly towards me. That's 5. Tender. It's okay?
Yeah.
S1. S2. S3 more tender or S2 more tender?
S3.
S3. It's not moving as much. Or S4.
S3.
S3. S3 on the left. Yes?
Yeah.
Static palpation. So right when we get here, we can see the swelling and edema right there. And you can see that swelling kind of go all the way to right about there. Tender?
Yeah.
Yeah. 1, 2, 3, 4, 5 more tender, 6 more.
6.
So we're starting at 6. I'm going to push harder at 7.
Okay.
You see the difference. You feel it.
Mm-hmm.
Okay. 6, S3. Now let's go to the neck. Sat, 7 or 6?
6.
7, 1. No. 7, 6. 6?
6, yeah.
Okay. 1. Oh, yeah. Oh, relax the head back, shoulders back. I'm not cracking nothing, okay? I'm just checking stuff right now before we start. You can feel
Ooh,
it right
yeah.
there, C1. Not so bad, right?
No.
Okay. Let's do divorce test. We're isolating lower cervical spine. You'll learn that in kinesiology. Okay, look up at the ceiling. This is the lower cervical spine. Turn left. Turn right. You have definitely a more motion to the right. Yes?
Mm-hmm.
Okay, now head down. Turn left. Turn right. Now, if we go down and left, or if we go up, look up and left. Which one bothers you more? Up and left, down and left. It actually feels worse here.
Ooh, yeah.
Okay?
Oh.
Down and left. So we're actually going to start at C1 today. Here's the process for today. C1, T6, S3. Before we get there, let's check the grip strength of your hands. Because those nerves that control the shoulder, look, right here. Stand up for me. Deco. Right? We know this is what we were talking about. The nerves that come out of they're called the brachial plexus nerves. come from the cervical spine. They go in, they power the shoulder, the arm, everything. Deltoid, C5, C6. Anterior deltoid, C5, C6. Okay. Now, I want to check your grip strength, compare both sides. I want to see if there's any muscle weakness from any of this. Do the right side first as hard as you can, squeeze hard. They're like, ooh, he's got a new toy. All right, relax. So that's 85 pounds. 85 pounds. 85 pounds. Left side, squeeze as hard as you can. Good. 70. Let's do it again just to make sure it's not fluke. We'll average it out, okay? Squeeze hard. Cool. Let it go. 65. It's all right. It's all right. Just squeeze. Boom. That's it. 63. They're evening out though. I think it was just a little ambitious on the first one. Squeeze hard. Good. 55. 55. That's all right. Squeeze. Just want to have a baseline. Does that feel harder to squeeze?
Yeah.
Yeah, right?
It's like over here.
55. But here's the thing. The power is symmetrical. So the good part is in terms of nerve, he has his power. I'm happy with that. The last one was the one we were looking at 3 times. It evened out. So if there was nerve damage to the muscle, then this should have been significantly weaker.
They told me I had a little bit of nerve damage over here.
In the shoulder?
Uh-huh.
Okay. You know which nerve they told you?
It started with an A.
Axillary nerve?
I think so.
Okay, C5, C6. Let's turn it on. Now, before we do that, let's have you raise your right hand up as high as you can. Good. And down. Left hand up until it hurts.
Right there.
Not bad. Okay. Stand up for me, please. Let's face the posters on this side. Let's do it again. I want to watch the back here. Raise the right hand up as high as you can and down. Left hand up as high as you can. Check this area out right here when he's... Raise your right side. Smooth. No restrictions there. Raise the left. It's already restricted right there. T. Around T2. Okay. Now, both hands overhead shoulder press if you can.
Like here?
Yes, sir.
Wow.
Okay, so we can't hold it there, right?
Yeah.
No worries. These are tests we're looking at to see what changes after the adjustment. That's why I'm doing that. Okay, go ahead and face the TV, please. Can we bring our arms like this? Can we externally rotate?
It starts right around here.
Right around there. Okay, come back. Can we bring the elbows up this way?
Kind of, not really.
No. Don't force it. Just tell me where it hurts because that's a good test
It's
for
right
us.
around here.
Right there. Okay. Do the right side. No issue there, right? Okay, cool. And hands down. Squeeze my hand. Squeeze hard. Good. Squeeze. Okay. Squeeze. 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 Let go. Squeeze. Squeeze again. One more time. Okay. Now, if I put my finger here, can you raise your hand up?
Oh shoot, it feels a lot better.
Jadoo. If I put my finger here, raise your hand up.
Feels a lot easier.
If I put my finger here, raise your hand up. Is it better?
Yeah.
Okay, hold on. Tell me when it's not better. Keep going.
I can still get pretty high.
That's T6. That's where it's starting.
Yeah.
You get it?
Mm-hmm.
All right.
I still don't have like full there, but it was like a lot more.
I'm showing you a difference.
Yeah.
I'm trying to show you. I didn't touch your shoulder.
Mm-hmm.
I'm just putting energy where the nerve pressure is. Look, 1, 2, 3, 4, 5, 6. Go ahead and raise it up and down. Now watch. If I go double gangster on you right here, lean into my finger here. Now raise it.
Oh shoot.
All right. Raise it up all the way. There you go.
I can't go all the way there.
Okay, but that's pretty damn good. Okay, now, Jadu. Alright, now Haneka. Do it again now.
Oh, shoot.
Still better.
Yeah.
Sorry, I gave him too much of the morning power. Okay, have a seat. Cool. Alright, we good? We're clear? You ready to get started?
Yeah.
Show time. We're gonna start with the foundation though. Ek, do, tin, 3. So, we're doing S3. We're short on the left side, so we want to torque it counterclockwise. You okay there on your arm? Does it hurt if you relax your arm down at all? Does it hurt in that position?
No, but I'm just a little scared.
Scared of what?
Popping out.
Popping out of what?
The socket.
You ain't gonna pop out, dude. Unless I pop it out. I'm joking. Put it where you feel comfortable, dude.
It's good here.
Okay? Cool. And that's the home run, baby. Gotcha. Breathe. Keep breathing. That was sweet. T6, PLS. Do-do-do-do. Ch-ch. 1, 2, 3, 4, 5, 6, PLS. Ooh, butter, baby. You good?
Yeah.
Check out the dimples. Let's walk. We got this side to the left, but we have a little movement on that right now. Okay. Can you walk on your toes?
Yeah.
Is that different? Not good, not bad.
Feels around the same.
Okay, walk on your heels. Turn around, keep walking, please. Good. Okay, now let's get to the neck. We're gonna wait on C7. I want to do C1. Sit back for me. There you go. There. Home run. Gotcha. That was nice. Look up. Turn left. Turn right. Look down. Turn left. Down and left, down and right. Okay. Can you try to do that shoulder press again in that position?
Oh, shoot. Feels a lot better. Still feel pretty weak, but
Okay, but we
Yeah.
got, how's the pain part?
that's not much at all.
Okay, stand up for me, please. Face the TV that way. Okay, raise your right arm up. Now, I'm not expecting one adjustment, all this stuff is fixed. I'm looking for change, I'm looking for a difference. Match it with your left now. Keep your right hand up. You got it? Have a seat. I'm not touching your shoulder. I'll crack your nose though. And before I do that, you better listen to your parents.
Ooh.
I'll do that too.
Yeah.
Yeah, I got you, girl. Don't worry, I got you. Don't worry. All right, now the fun part. Let's go do the nose. On your back. Okay, look. So this is the nasal. Look, this is the bone. All right. I'm not messing with the bone here. We get to the bone, then we get to the cartilage here. That's the septum. Okay. A septum is not the bone. Is not the septum. That's the nasal bone. The septum is the cartilage, and you can feel it already here. If I push on this side versus that side, we're going to sit there. Chin down. There you go. That's it. Gotcha. Deep breath in and out. Deep breath in and out. Poquito más. Poquito más. That's it. Gotcha. Mom, you can let him go. Now, as you're walking, tell me whatever's different with anything.
I feel like more air's coming in through my nostril.
Okay? How's the back? How's the neck? How's the movement in the hips?
I don't know if this is related, but I feel like my foot isn't turning as much as it normally
It's
does.
not supinating out.
Yeah.
Correct. You know why it supinates? To raise that hip up. It's compensation. There you go. Good job. So your homework while you're here for a few days, lots of walking, okay?
Okay.
You want to go to the mall and spend their money, do that too, but just walk, please.
Okay.
Please, lots, 10,000 steps. Squeeze. Relax the hand. Let's do the elbow.
Ooh.
That's it. Done. I'm not doing that side. Don't worry, I'm not doing that side. Let it go. Drop. There. Squeeze hard. Solid. I'm not doing the elbow. I'm doing the hand. You want to hold it back? You want to hold the elbow? If you
Okay.
feel, you want to hold underneath it just so you feel more
Okay.
confident. Gotcha. Squeeze hard. Come on, dude. Check this out. Let's start with the left hand. 65 was our last one. Squeeze hard. $70. Didn't get weaker. Good. Squeeze the right. $75. Okay. So we got a little more power after that. Cool. Now, ankles. Let's do the ankles. Go on your back. Now, for the ankles, I'm not yanking on the ankle today. We set the sacrum really nice. I do want to show you something though. Tender.
Ooh, yeah.
Okay. Slide down. Okay. Now, what I'm going to do, come over here, Shasha. We know that this side is shorter. You can see it's higher when we go. I want to just even them out a little bit here. Bring your toes back as far as you can, all the way back. All the way back. And what do you see? The left one goes further back than the right. So we need to work on this right ankle for him. So, inversion sprain we talked about. We're going to work on the talus. We'll look at the other stuff later. And right now we're working periarticular swelling and scar tissue, working it towards the heart, okay? And what we're doing is we're just trying to equalize this joint pressure. Fun, huh? Mm-hmm. Fun times, fun times. 5, 4, 3, 2, 1. Actually, I will do it. Maybe Mom and Dad will help me. Oh, juicy. There's a nice nub right here. Now, do you understand why you have compartment syndrome?
Yeah.
Yeah. What do your peeps at school say? Huh? Your peeps at school talking smack?
I have a friend that watches.
Oh yeah?
Uh-huh.
Cool. What's his name?
Jack Moses.
What's up, Jack Moses? What you got? Is he the only one that told you to come out? Supported you?
he was a supporter.
All right. What about the other guys?
I didn't really tell too many people.
About your, well, you see what happened, right?
Mm-hmm.
Why don't you describe what happened, dude? Because you experienced it. I'm showing them all the stuff. But what did you experience, right?
Raising my arm was kind of like, I don't know, I felt higher than it's been in a long time. This past 2 weeks, I have not been able to move it very high at all.
Mom, what did you see? You saw it go higher, right?
I did.
Okay, without pain.
Yes, sugar.
Does my nose look more even now?
Are you able to breathe?
Yeah.
That's more important.
Thank you. You know how Mom does to do that.
Yeah! Let it go. Let's walk it off, please. And you're going to walk back and forth several times. Now walk on your toes and see the difference.
Oh,
Oh.
I feel lighter.
Yeah. Tell me.
It's kind of crazy.
What's crazy? Tell me.
I feel lighter. I feel more explosive.
Mhm.
Ready to get back on the track.
Better now than never, right?
Mm-hmm.
Mm-hmm. Now, here's the test I did not do. Okay? I didn't go through chicken wing test or the shoulder. I didn't get into any of that. But what I do want to test is one more thing. This is important with anterior misalignments or anterior dislocations. Ain't nothing popping out, okay? Face that way, please. And the first thing I want you to do is bring your right thumb up your spine from behind. Yep, as high as you can, without pain, of course. 1, 2, 3, 4, 5, 5.5, 6. Bring that forward. Bring your left hand behind your back.
I get pain around there.
Come down so it doesn't hurt. Go to where it hurts.
Honestly, around like here.
Okay, no problem, but you can still go up.
Mm-hmm.
Okay, when you go up, does it feel like this thing is going to pop out? There's pain.
Yeah.
Go up. Go up. You're feeling it here in the front?
I'm also feeling it kind of like inside.
Okay.
Like here.
Got it. Come down slowly, please. Down. Okay. So right about there. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. That's a test for us. We want to be able to go higher as we go through. I am going to tomorrow set the scapula, because what we need to do is we need to make sure, look, the labrum is part of the scapula, right?
Mm-hmm.
If the scapula is out of alignment, then that labrum is not going to hold, right? So if we're looking at the scapula, turn around, let's just look at it one more time. Look straight ahead, and you can see, right, the left one versus the right one. Raise your right hand up, no issue, and down. Scapula is in its position. This is called a posterior lateral superior scapula. So it's turned this way. The glenoid fossa is facing forward. If it's facing forward, that humerus is not sitting in there correctly. So what we're going to do tomorrow is we're going to start to bring that scapula back this way. Okay? All of this is making it better for you. So again, it can heal right, and if you decide you need to go and get more invasive intervention, you're ready for it.
Mm-hmm.
Cool?
Mm-hmm.
Questions?
So
What questions?
I've been sleeping in my sling, like the surgery one, my surgery brace, just to make sure that like, you know, like I really don't want it popping out or anything.
Sleep with it, it's fine.
So that's
Yeah,
okay.
it's fine.
Mm.
I don't want you to think that, okay, look, you want to be safe, you want to have peace of mind when you go to bed.
Mm.
I'm fine with all that. So
Mhm.
you wear your sling. You understand everything I went over, right?
Mm-hmm.
Welcome to the office.